Good evening, and welcome to Health Plus Weekly. I'm Dr. John Podkowa. I'm joined by our co-host, nurse practitioner Hannah Raymond, and we are excited to welcome you back to another show. Tonight, it is just Hannah and myself.
Us.
Yeah, just us tonight, talking about actually one of our favorite things to talk about, kind of primary care, what's new in primary care. We're going to talk about some updates that have been in the news, some other things that people have written to us before in the past, things that we see in the office that we'd like to kind of share with everyone, maybe some other current hot topics. But we also are really looking forward to hopefully fielding questions from the people who watch at home. It's been a bit of a time since we just had a general medical show where you can write in with your own medical questions. And so really open forum tonight. If you're watching, please write in regarding questions you have regarding adult medicine. Unfortunately, neither Hannah nor myself take care of children, so we can't answer too many or really any pediatric questions. But if you have a pediatric question, we can hopefully steer you in the right direction because we have a lot of great pediatric resources at Southcoast. But we look forward to hearing from you. We also like to hear kind of where people are watching from. It's been a bit of time since we asked where people are tuning in from.
See how far our reach is. I can't remember.
It's nice. We had New Hampshire before. Yeah. I think we can always count on Hannah's mother tuning in from Rentham. Absolutely. Grace is usually watching from somewhere in my family, and lots of patients, kind of tuning in. So, and then how your summer's going. So, with that.
The biggest story in the news this week, right?
Mm-hmm.
Recall of a very common blood pressure medication. It's called valsartan.
Yep.
So I know that we were talking about it kind of in the office, that the story had broken in the United Kingdom, that the drug was being recalled, but then I think it was Monday morning it finally hit the United States as well.
It was a Friday night. We were watching it and kind of paying attention to it and seeing that in why there's this recall is in certain components of the drug, not the drug itself, but how they make the pills or the tablets. That one part of the ingredients may be what's called a carcinogen or called increase someone's risk for cancer, but it's not in all medications. And it was actually one of my patients reached out to me and said, do I need to worry about this here? And I researched and looked at it and said, no, not yet.
As a Friday
evening, it is not yet in the United States. And then shortly after, I just sent off my email to her to, wouldn't you know, I got home that night, opened up my email, and there was breaking news, from the FDA that they were recalling certain valsartan medications in the U.S.
Yep. So what do we do when if you're on that medication, what's the first step? Now, as you said, it's not every single manufacturer of the drug, but in kind of talking with the pharmacists that we work with every day, it's a majority of the manufacturers for the most common products of valsartan. So the best thing, and what we've been having a lot of people do, is just to call your doctor who has prescribed you that medication, and luckily there are some really easily available alternatives. Within the same class of medication. There's a conversion, and it should be an easy switch over. We were talking about kind of, we should just make sure that the dose is still appropriate and that your blood pressure is still well controlled if you do make any type of change, kind of even within a class of medications. But it's not anything more difficult than a call to the prescriber
or the pharmacy, our pharmacists
Yeah.
Who help with us, whether they're Southcoast pharmacists or the other brand name retail pharmacists, are just tremendous assets in your care, and they're up to date on this information also because the name of the medication valsartan may or may not, the one you're on may or may not have to be changed out for the time being. But if you're on the medication, I think reaching out to us, or your primary care physician, or your cardiologist, whoever's prescribing the medication, and also your pharmacy, just to see.
Right.
So
that was the biggest story that we saw.
A
couple of other things in the news this week were kind of the use of antibiotics in non-primary care environments, and maybe some data saying that prescribed in cases that may not always be appropriate.
Sure.
So I think that's always a great thing to touch on. When are antibiotics appropriate? Or we don't know that always 100%, but just kind of in head-to-toe certain scenarios that we can go through.
We see it every day in terms of, people want to feel better, they're sick, and whether or not an antibiotic is appropriate. Because with any, I think it just kind of goes to a general kind of better discussion in terms of when you're deciding on what to do to treat people, like we talk about all the time. there are risks and benefits to everything we do for patients. And there's risks and benefits outside of medicine as well, but when we take care of patients, fundamentally what we want is the benefit to be really high and the risk to whatever we're going to do to be really low. And as those
come together,
then it becomes more of a kind of a difficult decision or a bad decision, because in certain cases the benefit's not there at all and there's just risk and it's just kind of unacceptable. So one of my favorite mentors told me in terms of medicine, it's like there's no free lunch. Like, in terms of every procedure, medication, there's always a side effect.
Always a side effect, yeah.
And why do we worry about the overuse of antibiotics, or if it's not appropriate for antibiotics? And the most, there's several reasons, right? Like, number one, antibiotic resistance. So unfortunately,
right. So bacteria are smart, and when they're exposed to an antibiotic that is going to try to eradicate it or kill it, it can actually change, and then the next time it sees the antibiotic, it won't be effective. Yeah. So we worry about that kind of, on the personal level sometimes, but then, in the greater kind of community and
this isn't like an academic worry. This is, that there are certain strains of bacteria that affect, whether it's a urinary tract infection or infections that cause pneumonia or other infections in the hospital, and the skin infection that are increasingly not responding to the antibiotics we have. And so it's worrisome because it takes a long time to develop new antibiotics.
And there's not many on the horizon. Unfortunately, it's not the big moneymaker in terms of pharmaceutical sales. But, so we're limited in what we have in terms of using antibiotics. So it's part of our daily life to try to, figure out where it's appropriate and try to be judicious about it.
And they can have side effects. Like, certain times they can elicit allergies that people may or may not know. They can interfere with other medications that you're on. They can upset your stomach sometimes, and there's a disease called C. diff, where the antibiotics disrupt because we are filled with good bacteria that we kind of cohabitate with, and so it can disrupt that and can cause a lot of problems. So
we actually have an applicable question from Mark. Hi, Mark.
Well, Mark.
He said his ears are ringing after 6 weeks of vancomycin, which is an antibiotic, and Zosyn, which is another antibiotic. He realizes that there's side effects, but will they eventually go away? So vancomycin, one of the side effects can be ototoxicity, or kind of a irritation of your ears, causing ringing sometimes. Have you seen it go away in your?
Yeah, and so yes, and also a lot of other things can cause ringing in the ear. So it may be true, unrelated. I think getting checked out, having your ears examined, and to see if there's anything kind of going on in the ears. And if you haven't had a hearing test, that's the other one of our first steps in terms of kind of ringing in the ears, and evaluating also, Mark, other medications you're on. So it may be the cause of it, but there might actually be also something driving it. So I would, we usually recommend, definitely, having the hearing assessed, looking in the ears itself, looking at your other medications, and we have some great nose and throat resources if further testing needs to be done.
So could be related, but bottom line, probably get checked out and see if there's other causes that could be reversible a lot easier. Sometimes just fluid in the ears, with allergies can cause that. I love it. We've got tons of questions coming in.
Wow.
So keep them coming.
Absolutely.
Kind of going along the appropriate use of antibiotics line here, Mike has written in, he has a senior female that he knows and has had somewhat frequent urinary tract infections and has been prescribed ciprofloxacin a number of times after culture tests. And any thoughts and alternatives on that medication?
Yeah, go ahead. What were you going to say?
So I just think it's important to kind of, why to come to the doctor or to be seen for a urinary tract infection. So we'll, initially the classic symptoms are, burning, pain, frequency, urgency of urination, kind of low back pain, kind of lower abdominal pain, sometimes fever, chills, and some flank pain. And so that's all well and good, and that's pretty well predictive of a urinary tract infection. But the reason that we want to see you is to actually get a urine sample so we can send it for what we call a culture, as you mentioned, Mike, so we can actually grow out the offending organism, and we can actually see then from that culture what antibiotic will work. So if ciprofloxacin has been an antibiotic that has been shown to work for that bacteria several times, do you switch it up sometimes?
Actually, the data's changed on this because of this
yep.
resistance, like we were talking about earlier, that it was first-line agent for urinary tract infections, but it's no longer
Nope,
recommended as first-line. But depending on everyone's allergies and other medications, it may or may not be appropriate.
Right.
And in the older women, it's interesting, we just had a bit of a run on this in our own office about older women having kind of recurrent urinary tract infections, and there might be a bit more kind of due diligence or investigation of what could be causing them, correct?
And there's certainly local resistance. So, we do know that for certain medications for urinary tract infections, if the local resistance rate, I think it's over 30%, then you're actually going to use another antibiotic as a first-line medication. So those are all decisions that we make every day, and kind of based on your history and how well you've done in the past with other antibiotics. So I guess, Mike, the long and the short of it is it could, based on the culture, if their culture confirmed urinary tract infections and ciprofloxacin works, that's reasonable.
And I would say, exactly, but if she keeps getting them, why does the bacteria keep coming back?
Right.
And whether it needs to be a longer course of antibiotics, or is there something happening in her genitourinary tract that's predisposing her to this? Right. And so when we work with this, and some of our urologists help with this, there can be
so
kind of a host of things.
Recurrent UTIs are 3 to 4 UTIs within a calendar year, and that's culture confirmed. So I always, in my mind, if I see somebody coming back and back, you keep a running tally and maybe even look back at the labs, and then that will warrant another evaluation from the urologist as well. Because there's a lot of changes that we can make to help out with that. And that being said, the fluoroquinolones, there was actually an update today, speaking about in the news. So ciprofloxacin is a fluoroquinolone antibiotic, and actually for some instances they wanted the labeling to reflect more of the risks than the benefits. So like you said, you want the risks and the benefits of antibiotic use to be far apart. And so this is just another kind of layer in choosing.
Yep.
So let's see, what else did we have? So we have a question from Margaret. We're doing rapid fire here.
That's okay. This is what we're used to.
This
is
every
primary
day,
care.
right?
This is every day for us. This is one of the great things about it. One room to the next. There's different topics and different complaints.
Within the same room.
Yeah, absolutely.
So Margaret's asking, is mild neurocognitive disorder due to multiple etiologies just another word for dementia? And she loves this show. Thanks, Margaret.
Thank you, Margaret.
So mild neurocognitive disorder due to multiple etiologies. Have you?
I would say that is, I do not think that's necessarily synonymous with dementia.
Right.
I think that there are a number of things that can affect memory and recall. There are many things that can cause dementia. There's Alzheimer's is the most common cause. There's vascular disease, or there is Lewy body disease. I don't think I don't think it's necessarily synonymous, or it's the same thing, Margaret.
But it is, so we do also have a tendency of kind of naming one thing multiple different names. So if you have a question about, what that means for the particular person, I think it would be reasonable to clarify that, just moving forward, because it could be, multiple etiologies. Is it vascular? Is it Alzheimer's dementia? Does it just mean it's a mix, and it's creating this mild cognitive impairment, which is another word for probably what you just said. So it would be reasonable to kind of clarify that. So, Stella says Dr. Podkowa is her doctor and the greatest doctor. So Tristan,
I really am lucky to have. I wanted to say, who was out there listening, we are so fortunate to have, perhaps, I don't know, I just am really grateful for her. We have great patients, you know what I mean? It's just great. I mean, there's so many of them every day that, we're happy to be part of their lives.
That's why we love the show too, to kind of expand that as well.
Yeah.
So another question from Tristan asking, how much exercise can bring down your blood pressure even on medications? And can you over-exercise, making blood pressure worse?
So definitely we can overdo almost anything. So a healthy amount of exercise. It depends on your age, your overall level of physical activity and physical fitness. Because it is a stressor, it can. And actually when we do exercise in the while you're exercising, your blood pressure actually goes up.
Goes up, and that's good.
That's a good thing.
Yeah, yeah.
When we test people, right, for stress tests on the treadmill, the cardiologist, when we order stress tests, one of the things they monitor is your blood pressure. And if your blood pressure goes down when you exercise, it can be bad, or it can often be a negative impact. But exercise, it certainly can be part of like a healthy lifestyle in terms of lowering your blood pressure, along with diet, lowering salt, eating better, removing alcohol, getting enough sleep, stopping smoking. So it's certainly a component of it.
Right. Oh, we have my aunt tuning in from Colorado, so this might be a new.
This is a new personal record for the show to be in a different time zone.
Yeah.
All right.
And Tilly's watching too. Hi, Tilly.
Hello, Tilly.
Doreen is asking, what is your experience in treating people with mast cell issues using antibiotics? How would you treat them, seeing as the possibility of an allergic reaction is high? Oh,
Doreen, thank you for asking. Unfortunately, I will honestly say that's outside our area of expertise. In terms of, I think you may, whether it's an infectious disease or hematologist, blood specialist to answer that question, but I really, I personally, I don't know about you. I don't feel smart enough, or you know what I mean, or just confident enough to weigh in on that. If we can more than happy to get you plugged into. We work with some amazing, blood specialists and infectious disease, specialists right in our own building in Fairhaven.
And a question from...
wow, they're keeping you busy over
there.
I know,
they really are. It's the end of the day, guys.
Thank you very much, everyone. This is great. We weren't sure summer if this was going to happen or not. We thought maybe people would be outside, but this is great.
So Kim's asking, do you have any experience in Graves' disease complications? She has pretibial myxedema and can't seem to find an answer as to what's causing her leg nodules. So maybe we can talk a little bit first about what Graves' disease is. So have you had any experience kind of diagnosing it, how it comes, presents to you in the office? What would be some signs?
Usually palpitations, jitteriness, the symptoms of an over or underactive thyroid. While on the textbook, underactive thyroid, constipation, lethargy, being tired, and hair loss and different things, and overactive thyroid, weight loss, diarrhea, palpitations. But they actually kind of mix in my experience in caring for patients. So it's just sometimes hard to tell, but classically with, an overactive thyroid,
which is
Graves' disease. They're jittery. You know what I mean? They are just, they don't feel well. Whether their heart's racing, sometimes they can have some diarrhea, sometimes there's weight loss. Not a lot usually, but usually they're just antsy in a lot of ways. And depending on how long they have the symptoms for, they get some of the other symptoms, from it. So.
And the concern is, so untreated Graves' disease can actually cause a situation where you can go into a coma, which is a medical emergency.
And it puts you at higher risk for different heart diseases. You can go into funny, heart rhythms, and so.
And as in terms of the leg nodules, I'm not familiar specifically with the relationship between Graves and the leg nodules. When we see that in the office, there are several kind of easy tests to figure out what's actually under the skin.
Often, when we take care of Graves' disease, there's medications that help treat the symptoms. The most common ones is the jitteriness, and we usually give medications that kind of slow the heart down and help with the nerves, because it takes a little while to get the thyroid and kind of regulate it, and then there's different ways of which to manage that long term. A lot of times in medicine, we talk to patients and tell them about that. Sometimes for however long you've had the symptom of the side effect of the disease, sometimes it takes that long for it to go away. Certainly with chemotherapy agents, some of the side effects come around longer, and then when you take away the agent, it takes a longer time for them to resolve away. Same thing with other things. So if you do have Graves' disease and you do have complications from it, we hope you're plugged in with an endocrinologist who's a doctor who specializes in the thyroid disorder to help manage that, because that's usually our patients who have Graves' disease, where we work in collaboration with endocrinology.
And that kind of being said, too, I know we talk about this pretty frequently, that we always try to, if somebody has a constellation of symptoms and they're coming in, we always, probably not by choice, but maybe just how your brain goes, you try to pin all the symptoms on one diagnosis. And so it's really important to kind of, every day keep your mind open to, things actually being unrelated. So different, you may come in with several different different symptoms, and you want them all to be related to one thing that we can fix, but it's actually, we need to open our minds a little bit to thinking about that. So we have and Kim says yes, she does have an endocrinologist, and she's had a thyroid radioactive ablation, which is a procedure.
Yeah, one of the standard operating procedures. Good.
Good. So we have a question from Carrie Ann. Hi, Carrie Ann.
Hi, Carrie.
What are your thoughts on prescribing testosterone for perimenopausal women?
Boy, they are not going easy tonight in terms of the questions.
Nope. It's just to let us know that people are still watching in the summer. Which
yes,
is good.
A lot of endocrine questions tonight.
Which is good.
And
so in terms of making a decision about any type of hormone replacement for perimenopausal women, I'm not familiar with the use of testosterone. The most commonly used are estrogen preparations. And that, does not go without a lot of consideration and a lot of conversation between the woman and the physician or the provider. Anytime you give a woman estrogen, so we call it exogenous estrogen that comes from outside of your body. Naturally it's produced in the ovaries and different
in the skin and fat cells, not skin, but I should say fat cells, but certain parts, yeah.
Within your body, it's produced in several places, and when that kind of goes away during menopause, you can have some very unpleasant symptoms, which are the kind of the classic vasomotor symptoms, that the hot flashes, and night sweats, and trouble regulating your temperature, mood swings,
kind of pain with sex.
Yep. But anytime that you give estrogen, you put a woman at higher risk for several complications. Blood clots always, endometrial cancer, especially if you have, retain all of your abdominal organs. So if you have your uterus and have your ovaries, and then breast cancer too. There's been some links to that as well. So as far as prescribing testosterone, that would, I imagine, I'm not familiar with that.
We don't prescribe it in our office.
No. But that would certainly be done, again, under the direction of an endocrinologist or maybe even a gynecologist, and probably would require some, baseline hormone testing, because as with anything, there's safe levels, and as you said, nothing goes without
Yeah,
side
and I'm
effects
sure,
and risks.
by the time you're researching testosterone supplementation that you've kind of worked through the other, modalities, but the good news is that there's a host of treatments and options for women suffering from the symptoms of kind of transitioning into menopause that work pretty effectively. So if you haven't, you may want to talk about those first, and it goes back towards kind of the benefit and the risk and where you are.
There's vitamin preparations can be helpful. Certainly there's
some
class of
antidepressants that were
medications
pretty
which have
effective.
been,
Yep.
And kind of help smooth the mood a little bit too, because we all know that that's, I think identifying that,
Gabapentin has a role, which is actually an anti-seizure medication that has been effective. There's kind of topical, estrogen, preparations that women use that are, kind of low risk, but first based on kind of a baseline, like you said, health assessment of your risk factors for developing certain cancers.
Right.
And blood clots.
And no smoking, and if you have high blood pressure and things like that. So again, these are all really kind of important conversations to be able to have before making that decision, and we don't take it lightly in terms of weighing the risk as well. And then it's also good to kind of know what you're looking for in terms of those complications and what to do. So Mark is asking, he's on Tapazole, which is another medication that's used to actually control Graves' disease rather than
hyperthyroidism.
He's been on it for 6+ years. Sorry, my eyes are going faster than my mouth. Are there risks to being on such a medication for an extended period of time that you know of?
Yeah, methimazole and Tapazole has been out for a really long time. It's really nice. I think it's it's generic now. I think it's used, and I think that in that case the benefits greatly exceed the risks. And and I have, so I think it's again we work in collaboration with endocrinologists. It's not a medication that.
It's not a medication we often start people on.
I think in collab sometimes we do just to help get them started until they get plugged in, but actually in our experience, the benefits outweigh the risks, and it's a good medication, and it's an accepted medication for controlling the thyroid.
And also uncontrolled Graves' disease is not a better alternative either. So Kim says, thank you, you're welcome. And Mark says, this is a great opportunity to ask questions and greatly appreciated. So they're from Southwest Florida, so maybe that, I don't know, we'd have to do the mileage there between there and Colorado.
Thank you, Mark.
So we are all caught up in terms of questions. That was great. Keep them coming on any general medical topics you can think of.
Yeah, two other things that we wanted to talk about, certainly questions were seen in the office, some questions that have come into the show, but one, ketogenic diets, it's funny, we've talked a bit about them in the past in terms of, eating a high-fat diet to help kind of, transition your metabolism. And I just want to put this out there that I've known several people who are doing this, patients who are doing this, who have had tremendous success with weight loss, who are healthy, but we have checked their cholesterol, and their cholesterol has risen significantly, several weeks after starting it. So
the idea is that you're not eating any carbohydrates and actually minimal vegetables as well. So it's a protein-heavy and fat-heavy diet.
And
I've even heard of people taking, spoonfuls of olive oil right before bed because they haven't met the calorie requirement.
So, and then we can have a show further about it, but just if you're out there, I just want to put it out there too. People, you may know someone, just to really, I think it's important to put out there to make sure your cholesterol's checked and kind of compare and contrast to where it was and when you started and ongoing on it. The other diet that's really popular right now that I think I've actually do it and I like is intermittent fasting that you kind of found some data on. It's kind of in vogue right now, right?
It is the most popular diet in people under the age of 34.
Look at that, I'm hip. I'm 44 and doing a young person
stuff.
Hey.
So, and actually our own Kevin Gendro, one of the family physicians that works in the same building as we do, has had a significant weight loss, and he's gotten quite a bit of attention in the press recently about it, which is wonderful because he didn't actually exercise very much during and we, of course, everything works together, and now it seems like he's adding some exercise in, but as a good catalyst for some weight loss. It's an interesting, and I find it pretty. I think I started it first before,
Sure.
Of
course you did. Absolutely, Hannah.
It's kind of an easy way to diet or to live. So.
Yeah, and so it's not for everyone. So depending on the medications you're on, whether you're diabetic or not, it's not great. But it is basically just not eating during certain periods of day, and perhaps the easiest way to start is a 12-hour fast.
Right.
And it's a great way to start. And of course, you drink water, and you can have certain food and liquids and vitamin supplements. And the reason why it's beneficial is that it may help our body process food better. It may help with what's called insulin resistance in our body, and that's in terms of basically just how our body digests food and processes the energy. And then, some people go on to an 18-hour fast. But it's worth talking to your doctors about. But it's effective because sometimes it's confusing about what I should eat and when I should eat and different things. And this is a bit more of terms of, it's within reason kind of eating okay in the right portion control size, but just maybe limiting the time. And I think the 12-hour one is really effective in terms of, I am notorious for just, you don't do too bad with breakfast and, and dinner, but after in the evening, maybe with a bowl of cereal, some chips, like cookies at the, I find myself kind of gravitating in the pantry around 9:30 at night, just, hey, what's going on in here? So it's interesting. So I think Heather Haynes will probably come back on our show eventually. She's kind of a recurring guest on the program, and we'll talk more about it as well.
So we have a question from Joe, and I'll get through it here. He's asking our opinion on what would cause his arms to swell and turn hard after any kind of strain. It's not just a small amount of swelling, it looks like he's on steroids. Tons of cramping, and he's unable to hold his arms above his head. He's been tested for every autoimmune disorder, and all of the doctors here at Southcoast are stumped. They put me on gabapentin, baclofen, and prednisones, and he doesn't feel any difference. So, in thinking about kind of what you've already had done, Joe, that's a good place to start whenever you think of, kind of muscle weakness or muscle cramping or muscle stiffness. We always look at first any medications that could be causing those symptoms, and the most common medications are the statin medications that are used to lower cholesterol after people have been on the ketogenic diet for too long. And so, you know, in the absence of any of, and sometimes, you know, an illness can cause like a kind of an irritation of your muscles. So kind of in the absence of any offending factors in terms of medications, and then any offending factors in terms of, you know, did you really just start working out, you know, hard recently? We then look for underlying rheumatologic disorders that could cause kind of generalized muscle weakness. And there are a huge number that, you know, some we are familiar with and some that are, you know, certainly less common.
There can, and certain tests might need to be done in terms of, you know, I also look in terms of, this may or may not be done already, but structurally just an MRI or the CAT scan, depending on what you've had of the spine, to see, and there's certain nerve tests that you're talking about to see if there's anything driving it.
A muscle biopsy sometimes
it can be myotonic dystrophy, absolutely. Yep.
But, you know, and we, you know, the providers that we have and the resources that we have at Southcoast are wonderful, but there are certain cases where we know that maybe another opinion or a tertiary care center, an academic care center.
We are really fortunate to live close to, you know, Boston.
And Providence.
And sometimes, you're right, a new set of eyes on the problem, a new team, might be appropriate. You know, I think all of us who practice medicine kind of welcome that at some point, because we just want our patients to get better and feel better, and, you know, and sometimes, you know, the diagnosis may elude us, and so a new set of eyes on the problem that doesn't hurt sometimes.
And I when I'm, you know, recommending people, or if someone's thinking about another opinion kind of at an outside facility, I urge them to go and just kind of not say what has been done before in terms of a diagnosis, and just kind of start to finish the progression of the symptoms, and really not try to name it before, you know, before they're actually kind of assessed by the other specialist. Because again, if that's pinned in your mind, it's really hard to kind of go back from that. So we have another question from Holly asking, what do you think about the paleo diet?
Hi, Holly.
Hi, Holly. I think that's similar to a ketogenic diet in that you're eliminating many grains and carbohydrates, and certainly no added sugar, in kind of, you know, bolstering your body into a ketosis. So same idea?
It is. I think, I agree. I think you just nailed it in terms of, you know, there's all different flavors of the paleo diet, but like you said. And I think in the right person with the, you know, in depending on their kind of, you know, family history, medical history, kind of medications that they're on, I've seen patients, it's been pretty effective as a nice jump starter. I think anyone who's watched the show for a significant period of time knows my personal bias is towards a plant-based diet. I really fundamentally believe that long-term, the healthiest diet is a diet rich in kind of vegetables and getting most of our calories, you know, from, you know, whether it's beans, you know, and kind of vegetables and non-animal proteins. I think there's and that's based on just kind of looking around the world and the people in the world who live the longest. So I think, you know, in the proteins that you eat, I think, you know, kind of the leaner are better in terms of, you know, so fish, and in certain chickens, and, you know, and portion control on that, you know, try to limit, you know, proteins to even 2 or 3 times a week, and then the size of what we get. But
what's
I think
the Whole30? Is that
and so I've actually done that diet as well. I usually try to, you know, kind of try a diet every couple of years and different things, and so that's based on a really interesting book, and a good book called Starts with Food, and in terms of just, which is the truth around it is how much what we eat affects how we feel physically, mentally, and it's true. And so the short story is, you know, for 30 days you remove certain food groups, because the premise is that maybe perhaps from an evolutionary standpoint, or just our bodies aren't meant to get as much of them as we get in our current kind of and diet. So it's removing alcohol, sugar, dairy, and wheat for 30 days. And I actually did that diet before I switched over to being, you know, primarily a plant-based diet. And I felt amazing. My wife and I did it. We felt great. It was hard.
Did you crave sugar less?
Yeah, we just felt fundamentally better. And the first thing that became really apparent when we did that diet is how much of what we were eating was based on convenience. Because we're moving on the go, and you have a bagel, and there's cereal, and there's prepackaged stuff, and so eating cleaner. So one of the things is just being able to name all the ingredients and what you eat. And we didn't drink a lot of alcohol, so that wasn't hard. But you're kind of cutting the sugar out, and the wheat was interesting. But and then what you do at the end of the, I'm loosely paraphrasing it, but after you do the end of it, you introduce things one by one to see how your body reacts to it.
I see. So it's like a clean slate,
yes.
and then see how you do with them.
Yeah, and I can tell you, energy improved. I lost weight. I didn't have a lot of joint pain, but a lot of my patients who have a lot of joint pain and inflammation feel better on it, for sure. So I think it's a great diet, and then there's a website for it, and it's really popular. And again, I think it's good to check your labs before and after, but it's certainly one of the diets we recommend in our practice on a regular basis. I think it's a great jump starter diet.
In 30 days, you can do anything for 30 days.
You can do something for 30 days,
yeah.
and there's something about willpower with that. I think that's also good as well. Like, just come on, you can do this.
So big shout out to Peter Koheno, who's watching. He is the founder of the
yes,
show.
He is,
so
absolutely.
Moved on to Children's Hospital Boston. So hi, Pete.
We wish you well, Pete.
We wish you well. We miss you.
Yeah.
And a question here about how long does a Lisfranc injury take to heal? That's one of the ligaments in case you didn't know. Like, I'm telling you,
That's
like
okay.
you didn't know.
That's all right.
One of the ligaments in your foot. How long does it take to heal? And when are pain meds no longer needed if she had surgery a little less than a month ago? Any experience? Do you have any experience?
I actually don't.
No.
It's a bit more outside my area of specialties.
Yep.
We have, Dr. Chris Chillis and some of our orthopedic specialists and podiatrists who are in our organization who probably will.
But in general, kind of some of the ligament injuries in the joints that we kind of can't avoid using tend to take a little bit longer to heal. I think my mom just went through the same thing with a little bit of tennis elbow, and then wondering why kayaking, shoveling, and going to kickboxing is hurting her elbow because you use it for everything.
Yeah.
So we do know that can kind of prolong the healing time. In terms of pain medications, there's a whole host of different types of pain medications, whether it's an opiate pain medication that's given kind of immediately post-operatively. Generally those aren't continued for any prolonged period of time. And then you would just transition over to an anti-inflammatory or acetaminophen type pain medication. But certainly if the pain is not getting better, that would be worth a trip back to the surgeon or the specialist to kind of see what's going on there.
Absolutely.
And if there is any delayed healing, because there can be complications with any surgeries in terms of
and you have to be careful regarding the pain medication choice. So it's very important to kind of collaborate with the surgeon who did it, because in certain cases they can, you got to be careful with which one you choose to, just like you said, to promote the right amount of healing. Certain the opiate medications, the oxycodones, the Percocets, which have been used, and there's a role for them sometimes, but increasingly it's less and less, and they have their own side of kind of complications. So, yeah.
There's another question from Mark. He's curious to know our thoughts on eradicating your thyroid, so kind of taking the thyroid completely out. If it's problematic, kind of in Graves' disease, given the continued research and the importance of the thyroid working so closely with the brain to control emotions, etc. He knows somebody who had their thyroid removed and it did not end well. So I think the precursor to that is I always try to explain the thyroid as the thermostat for the body. It can be hot or cold, like you said, and it controls, has a hand in many of our functions. Cognitive, that can be one of the things that we look at if somebody's feeling a little off and fuzzy is your thyroid. So I think it's important to just kind of realize how widespread the impact of an abnormal thyroid can be. Do you have any thoughts on taking the thyroid out?
So my thought is that it's a discussion for an endocrinologist, because there are, like we said earlier, there's pros and cons and risks and benefits to everything. He's right. And weighing those in your individual case and kind of come to grips with what's best for you. We don't make that decision kind of in our, as a primary care doctor. We definitely, like I said, kind of, rely on our endocrinology colleagues to make the right choice. We have patients who have had both, who have had their thyroid ablated, and but are also or others who are on medication. So.
And when you take the thyroid out completely, then you're on lifelong medication to replace because your body still needs those hormones. And that can be a little bit of so there's 2 different types of thyroid hormones that are, used by the body. And kind of getting that balance right from an exterior perspective can be a little bit tricky, and could certainly take some fine tuning, and we appreciate our endocrinologist colleagues' help with that as well. We have my aunt watching. Hi, Annie. This is a lot of family.
Wow, Hannah.
This is good.
Yeah.
And Sherry Francis says hi.
Hi, Sherry.
And Tilly's wondering if we can share the website for the keto or the paleo diet. So we'll look into that and share that after.
Absolutely.
A question about a snowboarding injury, falling on their elbow and tearing tissue in the shoulder about 3 years ago, and still gets pain. At times, needs to move her arm and using the opposite arm, actually. Any recommendation?
So shoulder injuries are common and hard. You want to talk about like joints in muscles and tendons and ligaments that we use repetitively all the time. So, great question.
Shoulder's not a good joint to begin with.
It's complicated. So there's 4 major muscles that hold it on, and so whether it's arthritis involved, whether it's inflammation or a torn part of the muscle, so getting a good evaluation either by your doctor, and then a lot of times it's physical therapy may or may not help with it. The symptoms have been persisting for like as long as her question here, maybe perhaps an MRI at that point. We have some great shoulder specialists, but I would say that's kind of well beyond the normal kind of healing process, and so I think that's definitely worth getting more further evaluated. First with a good physical exam, maybe starting with some plain X-rays if you haven't had them.
But anytime there's any weakness involved,
you're worried.
We get concerned.
Absolutely.
So there's weakness that comes from pain. So if you can physically do it, but it just hurts, that's one thing. But if you can't lift your arm, or if you can't lift a limb, that's certainly something that we kind of raises our antennas a bit more. So we have a question from Anna about what causes hand shakes. Sometimes she doesn't even realize until someone notices it and mentions it to her. She's on thyroid pills, and she goes for blood work every 6 months to check those levels to make sure the dose is appropriate, I'm sure. And she was able actually to get her cholesterol down, but her hand shakes happened kind of regardless of all of that.
Yeah.
So,
and that is, that's another thing we see pretty commonly in the office, and there's a few things that cause what's maybe called a tremor, and there are also things that can cause the shakes. Perhaps one of the most common things we see in the office is what's called an essential tremor, and that is when people notice it is, one, if there's a family history. So if this is when, and one of the things we want to talk about tonight is really important, family history and how much it can shape and influence like your own medical care and knowing it really well. So if there's a family history of people having shakes in your family, it might be what's it's called an essential tremor. So sometimes people's hands shake, if you can see it. Sometimes people's heads shake a little bit. And those shakes, often kind of occur when we get a bit older, there's not a clear cutoff. And they actually get worse when we go to do something. So if people hold like a cup of coffee or a drink, or going to do, or sew a button on, or, and they notice them. And so that's that. And they're not dangerous in the sense that there's nothing in the brain, or, it's not a sign of Parkinson's causing it. And there can be medications and some lifestyle choices that we can make to make them better. Such
as one of the big ones we've found recently, isn't it? A glass of alcohol per night. Yes, that would be one of the cases where that might help.
If what were you going to say?
Nope, go ahead.
If you're shaking or tremoring, while you're kind of sleeping, or people notice it while you're just sitting there watching television, say something and you have it, that's different. And that's maybe a bit more concerning for a disease called Parkinson's disease. And that usually is what's called as a resting tremor. So you're laying in bed, you're sleeping, and you wake up and your hand's doing it. If you're watching television, or you're just kind of noticing it. Symptoms that may go along with Parkinson's is often kind of stiffness. Usually balance becomes affected. One of my patients just recently diagnosed with Parkinson's disease, and handwriting is an early sign of maybe Parkinson's. And what happens is your handwriting gets smaller and kind of a bit harder to interpret. People sometimes lose expressions in their face. They smile less. People think they're grumpy, and it's actually they're losing some of the muscle function in their face.
The way you walk can change too, a little bit later.
Certain medications can cause, a shake or a tremor. Thyroid, we've been talking, so that may or may not be associated with it.
Yep.
Alcohol,
The alcohol. Some of the medications we use for bipolar disorder can cause shakes. So, kind of if you've had there's a multitude of different things that can cause it. Some of them are benign and some of them are not. We would want to kind of differentiate between those. Yeah. And certainly if it is a benign kind of essential tremor without any type of underlying neurodegenerative disorder, that there are things that you can do to help it. So.
Great question.
Yep. Mark says, thanks for letting us pick your brains tonight and taking time out of our busy days. Thank you. Thank you for asking all the great questions.
It's actually no problem. People ask us all the time in a way, like why we do the show still, because it's late. It is like, I think in the course of doing primary care, we see a lot of patients and sometimes you're rushed. So to spend an hour to talk about it. To
what you want to talk about, not what we want to talk about.
It's probably like outside of like taking care of the kids, and I love it. I mean, it's such a... Medicine's like there's so many great things to talk about. I remember in medical school, it used to drive my wife crazy because we would just talk about it, my colleagues and I, like forever in terms of just, can't get enough of it.
So we are all caught up in terms of questions.
Oh, good.
Yeah, so that's great.
So a couple updates in primary care, kind of what's new. We kind of routinely run through one of our databases. So we'll kind of go through. One is, family history in breast cancer risk among older women. I think, a lot of times we see women in the office who, and as people get older, but say women about, like, do I need mammograms anymore? Is there a certain point at which, I don't need to go, and in terms of, certainly with breast cancer, the bad news is, unfortunately, there's not a point at which you age out for your risk of breast cancer. As we get older, as women get older, their risk of breast cancer just kind of continues to rise, unfortunately. And so what one of these new studies found is that family history is really important to breast cancer. It's not just for young women, but for older women. And so, and this is going to tie into something else regarding ovarian cancer, but I think trying to reinforce out there that it's really, really important for you to know your mother and father's and your siblings' history. Beyond that, a little bit more, but certainly first-degree relatives, brothers, sisters, mom and dad. What they had, what they died from, because it can shape. Our decisions in terms of how we screen and manage certain people. Yep. So if there's a cancer, find out what type of cancer, when it occurred, what type it was.
The age at onset is really important too, and because that can, if somebody developed colon cancer in their 80s, that's certainly different than your father developing colon cancer in his 40s, and that would change. As you kind of come into your 30s and 20s and 30s, that would change how we would kind of screen you. To primary. And
there are certain cancer syndromes that are important to recognize. So when we go through and talking to people regarding their family history. So, breast cancer is very common, but, in terms of if there is a lot of breast cancer in your family on one side, so say it's your mother's side and her mother had it and her, sister had it, and, it kind of penetrates through. Certainly women who had breast cancer at a young age in your family, if there's a woman who had, breast cancer before the age of 50, if they had breast cancer in both breasts is concerning. Ovarian cancer, if there is, if you're a woman, or even a man in terms of, but if there's your mother, if there's ovarian cancer in your family, it's actually really important to bring it up to your doctor because it can be linked to a genetic abnormality that puts, women at higher risk. And this is important for women, but it's also important for men who may have daughters, and so it's really important to know this family history. Because what you're passing on. So, kind of simple, low cost but effective ways to prevent some illness and manage your health is it's family history. So,
and I think also when we had Dr. Blanchard on, we were talking about the recommendations for ending, stopping screening and certain things, and she said, basically as much as if you want to keep going and would want to keep getting treatment, then we'll keep looking.
Absolutely, yeah. So and if you can tolerate the treatment, generally,
and
absolutely.
So again, it's a conversation to have, but don't, we try to reinforce that. So if most of the recommendations are stopping screening for cervical cancer at age 65, it doesn't mean that that's a hard and fast rule. And if you would like to be screened, and we can talk about the risks and the benefits of if we find something and what you'd like to do, and it all makes sense within kind of what you see for your life, then that's fine, and we'd be happy to do that. At least in our practice, I can speak for only.
Skin cancer screening, I think if there's family history, if there's a family history of melanoma or other skin cancers, I think the recommendation is you should get a good skin exam. We have a couple great dermatologists in. Also, if you have a history of funny moles or that have changed,
fair skin.
Absolutely, making sure you get an annual skin exam. The other reason why it's worth going to see a dermatologist is they can teach you about how to self-assess and look at your own moles. There's some guidelines we look for, the ABCDs of skin lesions, and whether if they're asymmetric, meaning if you drew a line down the middle of your mole and flipped it over on itself, it should kind of line up.
Yep.
What the borders look like and the colors, it shouldn't change, and how big it is. So, and also now that summer, we can't overemphasize the importance of sunscreen. It seems kind of not super sexy or exciting, but it actually really matters.
So if Lori's watching, that was all you. Thank you. Talking about sunscreen. But it is important, really important. And I think, you can start using sunscreen on infants after the age of 6 months safely. So before that, you're going to want to just cover head to toe in the sun for infants. That'll be our pediatric pearl for
there
the
we
day.
Go. Colon cancer screening, I think the most important thing we want to talk about colon cancer screening is colonoscopy is not the only way to be screened for colon cancer. We think it's the best for a majority of people because it's diagnostic and kind of therapeutic at the same time. But a lot of people are resistant to colon cancer, colonoscopies. The prep is not easy in terms of, and
it's a day out of work.
It's a day out of work. Yeah. But colon cancer is real. One of the leading causes of cancer deaths in this country. Unfortunately, you won't have symptoms. When you have symptoms, it's likely advanced colon cancer, and your risk of being cured from it is significantly lower. So I think it's really important that we make people aware of that. There are other options you can talk about, right, Hannah?
Yep. So the guidelines, if you have a clean colonoscopy, no polyps and no kind of high-risk family history situations in terms of colon cancer or abnormal polyps, every 10 years is kind of the gold standard with that. There's also kind of a lesser invasive camera test called a flexible sigmoidoscopy, and that can be done every 5 years. And now there's a whole host of different kind of at-home tests and tests that we use in the office that actually test the stool. And it's looking for not only blood in the stool, which can be caused by a variety of different, hemorrhoids and just a little bit of irritation in the mucosa, or a tumor, which kind of alert us to maybe the need for an additional diagnostic testing. And then there's other kind of at-home stool tests that identify actually on a cellular DNA level some of the changes that occur with the more concerning polyps. So the long and the short of it is that colonoscopy is not the only modality that we use to screen for colon cancer anymore, and we would rather have you do anything than nothing at all.
Yes, absolutely. And you can talk to your doctors about, kind of the benefits of colonoscopy is like the furthest gap in between having to have it done if it's good. But the other tests, some are annually, or some of the just testing your stool tests are every 3 years, depending on which one you do. And then regarding colon cancer screening, usually it's 50s typically is like the age we begin screening. There may be 45 based off of some other risk factors, and certainly if your family history, mother or father, siblings, whether they have some polyps or they have diagnosed with colon cancer stuff, that would certainly change in when you begin and how often you go for colon cancer screening.
And that being said, too, if you have done one of the screening tests with the stool that has come back positive, it actually yields a better result on the colonoscopy, because you will need a colonoscopy after, but in a way, whoever is performing it knows that they're looking for something. And so there's actually a higher rate of, yield in terms of taking off those polyps and identifying those abnormal areas. So, anything is better than nothing, and there's a lot of different options outside of the colonoscopy, so it's a conversation that we'd love to have.
Good.
Grace is watching, so hi, Grace.
Hey, Gracie.
What would you like to talk about next?
So there's another topic in terms of updates that, and I just was speaking to a patient today, a new patient who was great, regarding quitting smoking, which is perhaps one of my greatest, passions in terms of getting, helping patients get healthier. You cannot overestimate or kind of overemphasize the health benefits of quitting smoking. I mean, it just
Immediately, immediately.
Yes.
Yeah.
It is, I always, in terms of trying to get people to raise their awareness of, how significant smoking is for them is, sometimes just to have them do like a life insurance quote for themselves online and see and put smoking and not smoking in and how much more expensive it is. And, smoking, people worry about cancer and that it increases risk of cancer, but fundamentally it increases risk of heart disease as well, which is, so cancer, heart disease go 1 and 2, and in terms of, cause of death in Massachusetts. And so new studies came out that showed, like, because we hear this a lot, well, I only smoke a couple less than a pack a day, a couple cigarettes a day, and unfortunately...
Or if I'm drinking, I have a cigarette, here and there.
Even smoking 1 cigarette a day increases your risk of cancer and heart disease. So don't be kind of lulled into, just a couple cigarettes a day isn't bad. Mm-hmm. Yeah, because it really is. And I think, there's really good, there's some evidence that just mentioning quitting smoking to patients helps them quit. Mm-hmm. So I'm taking this venue again to kind of hopefully broaden and reaching out that perhaps at any given point there's a lot of people watching the show that, we haven't spoken in a while. We're going to have a show, again on it about quitting smoking. But smoking is just not good. Most people know that, however, but but in quitting is perhaps one of the greatest things you do for your overall health in terms of lowering your risk of heart disease, cancer, high blood pressure, and also the people who you love who are surrounded you. Because secondhand smoke is not without its own risks, and so plus it's expensive, and there's lots of great ways that we can help you quit smoking.
Yeah. Whether it's nicotine patches or kind of different medications that we can use. Counseling, there's hypnosis, there's all sorts of different things. So I was urging somebody today who was going to try nicotine patches. If it doesn't work, call me, let me know. We can work on something else. Don't give up after that.
No. And a misconception is like the more times you try to quit, the less likely I'm going to quit. Like, I've quit before, I'm just kind of doomed. Actually, the evidence is the opposite. The more times you try to quit, the greater the likelihood is that the next time you try, it's going to be the time. Right. So for everyone who's smoking out there or who knows someone who smokes, just try again. It is. It's time. Try again. Find something. Pick a quit date. Things that work is, finding a defined date where you want to quit, circling it on the calendar, preparing for it. You can talk to your doctor about whether or not, nicotine replacement therapy is appropriate or not, and some really good medications. 1-800-QUIT-WORKS is a great, phone number, resource, counseling, motivation we use. Because even smoking 1 or 2 cigarettes a day does not diminish your risk of cancer and heart disease.
And a testimonial from Kathleen.
I knew it! She was going to say, yes!
Came to Southcoast. She's so glad when you did because you were the one who got her to quit smoking. So that's great. We're so happy.
In quitting smoking, this came from when I was in Temple. I was taking care of a woman, who she wanted to quit smoking because there are so many things that we cannot control in our lives. In terms of things that affect us from a health perspective, life, genetics, job, work, stress, but you can control smoking in most scenarios, in terms of it's a choice. And this one woman kind of recognized some of that, and we got her to quit, and it really is empowering, you know what I mean? And it builds willpower. And so I love getting people to quit smoking because it's just great. And so it's so funny, Kathy, that you wrote in because I'm so proud of you because it's been a long haul and she's done great. So she's one of my first patients.
We're all caught up.
Are we?
Yes.
Good. Anything on your to-do? Do we miss anything? Look at that, 7:58. Actually, we're done.
I know. I think we're all good. We can always go through another round of kind of primary care updates in the future. So.
Thank you, everyone, for writing in. Thank you for the questions. While I love having people on the show to talk about their specialties and resources and services, I think at the heart of this is like my favorite show to do. It's just to talk about what we do every day is basically talk with patients and kind of field their complaints and kind of collaborate and talk about medicine. So it's what got the show started. And, Josh, our producer's off screen, we were talking about before. It was May of 2017 when we first did this. This is what kind of kicked off, Peter's and Josh's, kind of idea to do the show. So it's great that people still like it and still write in, and I guess there's still, a bit of a need for it. So it's great. Parting thoughts, any questions? Is there anything else in the queue?
We're good.
Good.
Till next week.
Thank you, everyone, for tuning in. Thank you for watching, and stay healthy, South Coast. We'll see you next week.
By the time I graduated high school, I think I was between 275 and 300. I had to buy my dress clothes at the Big and Tall store. Enough is enough. Southcoast Health gave me the tools, and here I am, with my health. And I was a 46 going into 48, and now I'm a 30-inch waist. I'm living proof to show if you put the work in on anything that you can get what you want. Take impossible, throw it out of your vocabulary.